If I can't get to the door, just break it down. I had to call 911 around midnight. I couldn't breathe.
We routinely see people with car accidents or heart attacks or strokes or huge lacerations.
The healthcare system is being systematically dismantled in an attempt to make privatized care luxurious.
People will die and have likely died as a result of the emergency department closures.
This would be really life-threatening on a weekly basis, if not daily.
In Canada, healthcare used to be a source of national pride, but now it's struggling. In Ontario, 2.5 million people do not have a family doctor. That's over 15% of the population. And if you live outside the major cities, the problem is much worse.
I don't have a doctor. I just gave up trying.
About 2/3 of those living in rural areas said they have no access to primary care.
Our healthcare system itself seems to be on life support.
Jan is heading out on a road trip to better understand the state of rural healthcare.
A 900-kilometer drive northwest of Toronto is the town of Wawa, Ontario.
My first stop is the home of Jennifer Pine, a resident who was lucky to survive a life-threatening medical emergency.
Jennifer!
Well, I had to call 911 at around midnight. I couldn't breathe. I was coughing and I couldn't breathe, and I fell off my bed. I couldn't get my phone. I crawled to the top of the stairs. I told the 911 driver to, if I can't get to the door, just break it down. I could not breathe. And when I got to the hospital, I found out I had severe pneumonia, and they had to put me on a CPAP machine. And I was on that for 2 days. Barely remember anything. And I was in the hospital for a week. So they got through the pneumonia, and then a couple of weeks later, I had to go to the emergency again because I had a hard time breathing. And the doctor said, no, you're not going back home, you're going back in the hospital again.
Her symptoms were severe, but her access to healthcare was complicated, not only by COVID, but a lack of local doctors.
Then they started looking at my heart and found out I was in heart failure. So then the doctor tried to get me a cardiologist to take a look at me. This was in March, and I didn't get a cardiologist to see me until July.
Healthcare has never been in such disarray. I've done this for 27 years now, and there have been bad times and better times for sure. But in all those years, it's never been like this. We've got severe shortages of primary care. That's like the front door of medicine. Your family doctor, family health team, community health center, nurse practitioner, the front door of medicine. You can't really access anything else without going to your family doctor, who then gives you referrals to specialists. It is the worst we've ever seen.
Without a local family doctor following her progress, Jennifer was on her own to interpret the advice from specialists.
They did an echocardiogram. They put color to look
tests
at.
And all that.
They did all that. And the cardiologist told me that, you have a 75% blockage and a 95% blockage on the right side. And on your left side, you're 100% blocked.
Jennifer had to fly over 300 kilometers to a larger hospital in Sudbury to see the specialist she so desperately needed.
2 weeks later, I had a cardiologist from Sudbury call me and say, we're going to do it in 2 or 3 weeks. And I'm like, great. A month later, I called the doctor's office. No, it'll be a couple more weeks. And this went on and went on until I finally had a heart attack in March.
With no continuity of care during this critical time, there was no regular family physician to recognize that Jennifer was getting worse and that her life was under imminent threat.
I want to make sure I got the timeline right. When you initially had gone to Lady Dunn, and they said that you need a cardiologist, that was in March.
Yes.
And then it was a whole year.
Yes.
Before
I had my heart attack.
Then you had a heart attack.
Yeah.
What do you want for people who don't live in the rural parts of the province or in the north about what it's like for somebody who has a chronic issue and they need specialist care, but they happen to not live somewhere in the GTA?
There's not much plan for healthcare at all anymore because healthcare policy has been driven by cuts and privatization. And so there's not actually a plan to measure and meet population need for care, which is the first job of a public health system. And if you live in northern or rural Ontario, you have been done a terrible, terrible number. And it's not like it was great years ago. Like, it's never been perfect. There hasn't been the kind of planning that we needed, not in decades now. It has never been worse. Total consensus of opinion. They can't deny it anymore. We just need some real answers.
Once I got the surgery, I had to wait another week before I got my surgery. Now, waiting all this time, I'm like, why is it taking so long? Why? They told me that it was the hospitals were not taking patients.
An elective surgery.
An elective surgery because they weren't admitting unless I had a heart attack, which eventually months later, I finally had a heart attack.
Her case is not unique. With too few family doctors to go around, many patients experiencing declining health end up in emergency rooms. Doctors like Mike Cotterill are left to shoulder the burden, often working 24-hour on-call emergency shifts at least once a week.
Like all emergency docs in Canada, I have to deal with it. Anybody and everybody who shows up to the ER, and it can be anything from sprained ankle to a major mental health crisis to road trauma.
Dr. Cotterill has been a family doctor in rural Ontario for almost 30 years. He is one of only 3 doctors serving the town of Wawa and surrounding communities.
The number of full-time local doctors has decreased, but we're really having difficulty recruiting new physicians.
One rural doctor told me, this is from her, she works in the north, and she said she had just come off of 13 days non-stop working on call, 13 days straight, day and night on call at a local hospital, and watched the health minister on TV say that the health human resources shortage was not as bad as people were saying. I mean, that just lays it out. The staff have held the system together. That's the only thing holding the system together. You know, we can't take them for granted.
We're headed to the Lady Dunn Health Center, which is located on the shores of Wawa Lake. And the hospital there provides critical services to about 4,300 residents in and around the surrounding communities. I'm meeting with the hospital's CEO and staff to better understand what impact the doctor shortage is having.
We're a small community hospital, 28 beds. We service the communities of Wawa, Dubreuilville, White River, Missinaba, partners with Mishipcotton First Nation and also Hawk Junction. On site, we have a 24-hour emergency department. We have our acute care or long-term care. We do have outpatient services.
How many doctors do you have on staff, and how many doctors should you have?
So for the group of doctors that we partner with, it's the Wawa physician group, and they are supposed to have 7 physicians, but currently have 3.
7?
Yes.
But 3 only?
That's right.
So they are working around the clock?
Yes, they are. Definitely has been a challenge for us and many hospitals across the north. One of the things that we often first go to is that there just isn't enough physicians in terms of being able to fill the positions. The continuity of care can be something that can be challenged.
For example, we could offer sort of full-time obstetrical services with cesarean sections, and it's been years since we've been able to do that.
The strain affects the entire unit, putting more pressure on nurses and ambulance services as well.
Yesterday when I was on duty, we had a patient who needed to go out by air ambulance for further investigation, and everything was set up. The air paramedics were here to take the patient, but there was no one to staff the ambulance to take them to the airport, which is ridiculous, but critical. So we were faced with thinking outside the box, putting the patient in my car or somebody's car to drive them to the airport. I mean, the airport is literally a 2-minute drive away, or putting them in a wheelchair and actually pushing them all the way to the airport. So if it were to happen that we couldn't staff the emergency with a doctor, for a night shift or for 24 hours or longer, that really the emergency would have to close. And, we routinely see people with car accidents or heart attacks or strokes or huge lacerations. So this would be really life-threatening on a weekly basis, if not daily.
The closing of emergency departments is perhaps the most dangerous outcome of the healthcare crisis today. Once thought unimaginable in Ontario, it has now become commonplace in some rural communities.
When we talk about ERs being closed and people having to drive to the next ER, you still have access to an ER, so why is that problematic?
In the farmland, across the southern and middle parts of Ontario, if you have a tractor accident or you have a car collision on the road, you need blood. There's no blood in an ambulance. You have to get to a local hospital. They stabilize and they transfer you. If you have a heart attack or a stroke, people can go to their nearest hospital. They'll stabilize and transfer you on. If you have an allergic reaction to a bee sting or an anaphylactic reaction to peanuts or something like that, the local emergency department is what's going to save your life. I mean, it's the difference between life and death. I mean, without question, I think people could understand that people will die and have likely died as a result of the emergency department closures. People sort of think, oh, this is a rural problem or a northern problem. But the truth is that in downtown Toronto, in every large city, in St. Catharines, in London, in Windsor, in Kitchener-Waterloo, in Kingston, Ottawa, the hospitals are full. Like, they're completely full to overflowing. We've centralized so many services. We've cut so many services from the smaller hospitals that everyone has to travel in to those hospitals for so much care, and they don't have the capacity. We don't have one extra iota. We shouldn't see any hospital service closures in Ontario. We have so little capacity to provide for the population. So this isn't just a rural problem. Every patient from Southern Grey Bruce, they're having to go down to Kitchener-Waterloo more and more for virtually every service. The hospitals in Kitchener are full. London is full. In fact, sometimes it runs different departments at 120%. That means every bed is full and people are stacked in the hallways. Some departments are running sometimes at 150%. I mean, no one runs their hospitals like that. It's dangerous. It means there aren't enough staff for the patients. It means patients wait in hallways. People's surgeries get canceled. They get backlogged. Like, it affects the health of all patients everywhere.
Yeah, it's tough. There's need everywhere.
Shiva Kale is a visiting doctor specializing in family medicine, also known as a locum. Shiva has flown in to help fill the gaps, a 12-hour journey from Halifax.
I find in urban areas like Halifax, where I practice, I find that there's a variety of need, but it's not as urgent. Whereas in Wawa or Northern Ontario, I find that patients, I think based on population, don't seek care or don't have access to care, and when they do, they're often more acute.
So we hear the term locum, visiting doctor, temporary doctor. What does the role involve?
For Wawa specifically, it's clinic, inpatient, and emergency department. I think emerge shifts are every 2-3 days. They're 24-hour call. Since I started, I've noticed that they've gotten busier and inpatient as well.
Are you guys relying on locums more than ever before? What does that situation look like right now?
Yeah, we definitely are. When we first moved here, we really only needed locums when any of the doctors were going away on holidays.
But things have changed. Temporary doctors are now an essential part of the healthcare system.
Now we have at least two locums here all the time to help us cover the emergency and cover the vacant practices in the physician group. We're totally dependent on them. Like, I think we wouldn't be able to maintain a 24/7 emergency department without locums, and a lot of patients would not be able to get clinic appointments for their day-to-day problems that they can now. So locums are an absolute necessity for us. We're lucky to have them.
Visiting doctors provide critical relief, But are they the long-term solution to the healthcare crisis in Northern Ontario?
When a visiting doctor comes, they're great, but you have to explain the whole history. And if I have a visiting doctor, that's a different doctor every time. So every time I'm talking to a doctor, it's like, oh, here I go again.
People with the same family doctor over a period of time do better. They're healthier, they have better outcomes. Being able to sit down with a patient and pick up where you left off rather than starting from scratch and getting to know each other. I think it can't be overstated. It's so important.
I can't imagine living in a community in Ontario where you don't have access to any kind of care. Locums have been used as a solution. Are they a solution or are they a part of the problem?
Well, there's no doing it without locums at this point, but I mean, they were sort of temporary. They were supposed to be temporary, in seasonal, when people needed vacations to offset a doctor shortage during a vacation or things like that. They're now permanent. Sometimes they're the only physicians in town. Actually, I just traveled through the north, and several towns that I went to, they are the only physicians. It's only locums.
Dr. Cotterall and his wife, Dr. Anjali Oberoi, have been in Wawa for nearly 3 decades. Together, the couple make up 2/3 of the total number of family doctors in the area. With retirement around the corner, there could soon be just one resident family doctor left.
You're in your mid-50s.
Late 50s, I would say. Yeah.
So you and your wife are probably thinking of retiring at some point. Doing 24-hour emergency rooms well into your 60s is probably not something that you guys imagined when you first settled down here.
I think we had always imagined or assumed that we could pass the torch along. Like I learned a lot of skills from the docs who were here after I got here. So we thought that would, in time, our role would be like to be the elder statespeople or the senior scholars. It's hard to imagine right now what happens going forward. Patients are asking us all the time, what's your plan? You grow older with your patients too. People that were middle-aged when I started my practice are elderly.
It's just scary. I mean, I know family docs who've held on, for 5, 6, 7, 8 years to try and get someone to take over their practice. And they're not supposed to abandon their patients, right? So you're not supposed to retire without someone taking over your practice. And it would have been unheard of 8 years ago for a doctor to do that. At some point, you got to let go. I mean, I've known physicians who would never do this, just heartbroken, have had to abandon their practice and orphan 1,000 patients or 2,000 patients, or in Kingston, 8,000 patients, because they retired. They had to finally retire. And then, people lined up down the street for blocks and blocks waiting. It breaks my heart and it infuriates me because this didn't have to happen.
In this current state that we're in, is this the worst that you have seen it?
Yeah, well, it was briefly worse before Dr. Breton signed on just this year.
Dr. Breton is one of very few visiting doctors to make the transition to becoming a full-time resident.
I think that having this visiting doctor program, it's necessary at this point, but I don't think it's the long-term solution. I think the long-term solution would be attracting people to practice comprehensive primary care. I love the geography here. Having come here so often, I've met a strong support network of people. I have good friends here, so this felt like the most home away from home.
Already, Dr. Breton has had a huge impact on the lives of locals in need like Jennifer.
I really like him. He's good. Yeah. He listens to what I have to say, and when he first looked at my chart, he said, a lot of things going on. So let's take it one step at a time. Let's deal with this.
When you mentioned his name right now, it sounds like some relief that you finally have someone that is here for you
Exactly.
Tell me what that's like with the journey that you've had.
Oh, it feels good because you have an advocate for you. Here locally, I can't call Sault Ste. Marie or Sudbury or Timmins and say, hey, I need an appointment for this condition that I have and I need you to look at it. Well, I can't do that, but he can.
Even with Dr. Breton now on board, Wawa and the surrounding communities still have need for former resident doctors. However, the urgent need for more doctors isn't the only worry. Simple administrative work has become a huge part of a doctor's workload and a huge part of the problem.
A lot of the disenchantment I hear from my colleagues down south have to do with unpaid administrative time and really the kind of disparity in how primary care is valued in the billing system. And because the 15 minutes I spend in an appointment it's not just 15 minutes, it's then you've got to chart, you've got to make referrals, you've got to review the labs and the imaging, you've got to stay up to date on the patient, you've got to refill medications. There's so much that goes on behind the scenes that is not reflected at all in how family doctors are compensated.
Doctors in Ontario spend an estimated 19 hours per week just on paperwork like medical notes and insurance forms. That means 19 fewer hours that a family doctor can spend on patients in need. The increasing workload leads to more frustration and burnout. At St. Michael's Hospital in Toronto, new technology powered by artificial intelligence is already reducing time spent on paperwork.
There are people who just do not like being doctors anymore because of these administrative tasks. A lot of people threaten, look, I'm going to retire. This is getting to be ridiculous. So the clinician the family physician actually came up with a great idea. He said, what if a computer could just listen to my conversation with consent, of course, from the patient, and they could just transcribe the entire conversation so I can focus on the patient, reduce that cognitive load, and maybe even save a bit of time.
Ontario Medical Association, of course, is partnering with us with a pilot allowing AI Scribe, which is essentially the ability for that physician to be focused on the patient and having the notes and the follow-up tracked.
What studies have shown, and there's a provincial-backed study, over 75% of physicians reported reduced cognitive load, that it actually helped them focus on the patient. They saved on average 3 to 4 hours per week, which is a lot of time that they could then direct to patient care. So you can actually see more patients because you're spending less time on these administrative functions. And over 80% of physicians would actually be pretty happy with continuing to use the Scribe.
AI Scribe has shown huge potential as a sort of digital assistant to help doctors with menial tasks. But another type of software called ChartWatch could be even more transformative.
A tool like ChartWatch, which helps us identify patients who need more services, are really valuable in settings where services are more constrained, because we can try to direct those services more effectively where they exist and to the people who need them the most. And I'm a doctor on our internal medicine unit, so when I come on for a week at a time, and I inherit 25 to 30 patients that I'm taking care of. So when I first come on service, the thing that the AI helps me quickly do is understand which of my patients are at the highest risk of having a short-term deterioration, so I can prioritize focusing on them, learning about them, seeing them first, right? And that happens then every day as I go forward. And it helps me organize my time. It helps me understand, which patients really need my attention in the acute moment. And that's really important because I, as a physician, cannot physically have my eyes on 25, 30 people at a time, right? But the AI tool can have its eyes, quote unquote, on hundreds at a time, right? It can monitor the whole hospital at the same time simultaneously and help clinicians know where to focus their attention. The way this tool works is that for high-risk patients, we devote resources as needed. We devote ICU care, we focus on them and try to rescue them early.
So you anticipate what they need in the future?
Exactly, and it's about providing those services really early. We recently published a study in which we looked at the time period after we deployed the tool, compared to the time periods before the tool, and compared to other units in our hospital that did not have the tool. And what we found was that when we deployed ChartWatch, we saw a 26% reduction in unexpected deaths on the units that used the tool.
26% reduction in unexpected mortality was, I think, a wow moment where we actually saw the outcomes and said, wow, this thing can actually help save lives. Seeing that impact is always so gratifying.
I'm very optimistic about it. You know, I really think that combining our technologies with the amazing people that we have in our system, that we can get to that space.
There's an incredible amount of potential for AI, but again, we have to view AI as something that's part of the solution. We have a lot of things that we can fix with data and AI, and if you think about it, healthcare is very data-driven. So everything that we do, from diagnosis, prognosis, treatment, communication, is very much data-driven. That being said, you can have all the data in the world, but if you don't action it, or if you don't have the right resources to be able to leverage that data in a meaningful way, it won't matter. So I think we can use AI to really structure ourselves around something that can really help us drive better care, but it has to be a systems effort, not just singular modular solutions.
Artificial intelligence shows huge promise, but it's just one step towards addressing all of the problems that our healthcare system is now facing.
The bottom line is we just are not training enough nurses and doctors. They've kept the numbers low going into med school. And, you know, adding a few extra spaces per year is just not going to resolve the shortages. It's nowhere near enough. So that is controlled by the government in negotiations with the Ontario Medical Association, and they need to open it up. We need more doctors and we need more nurses.
How are you doing today?
Today I'm doing great. My heart is healed, because when they told me I had heart failure, before I had all the blockages because my heart wasn't pumping properly. Now it's healed. I'm at 100%. But when you have so many issues, it's such a relief to have your own doctor that you don't have to explain every time you see them.
This is definitely an adventure.
Yeah.
We might have a shortage, but we still have healthcare. Like, it's still something to be grateful for, even with all the challenges that's going on.
What do you point to in terms of fixing the current system here in Wawa?
It's a loaded question.
It is.
Well, for one, I think that the healthcare system is being systematically dismantled in an attempt to make privatized care look luxurious. And we should incentivize people to establish full-time primary care practices. Some provinces, BC for instance, have started to change that model. I think the Ontario government could take a look at those models.
But I think we also have to advocate to be able to get more doctors and nurses and home care and you know, help for the elderly. You know, there are so many issues, but we just got to keep striving to do better.
The state of healthcare today is the result of years of neglect from successive provincial governments. Our doctors or nurses need our support to restore the medical services that are still a great source of pride here in Ontario and across the country. To continue the conversation, join us here and online, and we'll see you next time.